All right, thank you for the introduction, Dr. Elamogan. My talk is on the potential value in measuring perioperative Plavix response in predicting complications in neuroendovascular patients. Let's see, is it working? There we go. In terms of conflicts of interest, I have none. And I'd like to give special thanks to Dr. Levitt, Dr. Young, and Dr. Bass for not only including me in this project, but also helping to bring the project and all their valuable contributions to the project. I'd also like to thank Dr. Durfee for providing me the updated manuscript as well as the updated figures for this presentation.
And congratulations on picking the smartest people in the department to mentor you. Well, way to go. There you go.
They've been fantastic. So in terms of an introduction, so just to set the stage, we have to define what an aneurysm is. An aneurysm is essentially a weakening of the blood vessel wall. And then you have this outpouching, which can cause compression, and eventually it can potentially burst. And there's a variety of ways we can try and treat aneurysms, especially aneurysms in the brain. But there are one of the techniques are called neuroendovascular techniques, and you can use things like stents, as you can see here. You can coil them. You can do coil-assisted stenting, flow diversion stents to try to obliterate the aneurysm so that it doesn't burst and hemorrhage and potentially kill the patient. But anytime that you put something in a blood vessel, there's a potential that you can create clots. And so in order to prevent clotting, you have to use, we use something called dual antiplatelet therapy. And the focus of my talk is going to be specifically on Plavix, but dual antiplatelet therapy uses aspirin and Plavix or clopidogrel. And the reason why we use those two agents is because one, they're relatively cheap, and two, we're very familiar with how they work. And so that's to prevent some of the clotting, some of the what's known as in-stent stenosis, which is basically when you put a stent in to try to block the aneurysm, sometimes the stent can clot off. So in order to prevent that, we use dual antiplatelet therapy to try to prevent those events. And whenever you use anticoagulation, you don't want to over anticoagulate them because then that could lead to bleeding events. So we use an assay known as Verify Now Plavix to try to measure and get a feel for how they're doing therapeutically. And in general, for these neuroendovascularly treated patients, we try to put them for about 6 months. We put them on it for about 6 months. So in the perioperative period, we load them up with Plavix 5 days before the procedure. And then we measure a Verify Now 2 days before the procedure, just to see how they're doing. And if they're therapeutic, we go along with the procedure, and then we put them on dual antiplatelet therapy for 6 months to try to prevent any kind of in-stent stenosis or ischemic stroke that might happen within those 6 months. In terms of the clinical significance, our clinical question is, does doing this measurement of VNP, this Verify Now Plavix, does that actually help prevent hemorrhagic or even ischemic or thromboembolic complications in these patients? One of the controversies of sort of using Plavix and what is known about Plavix is that there is some heterogeneity, or everyone has different responses to Plavix. And so some people will do really well and they'll be in that therapeutic range, but others will not respond so well and they'll have increased risk of stroke or thrombosis. And others have a hyper response, which means that they have an increased risk of bleeding. And there's a lot of different things that can affect your response to Plavix. So things like your BMI, your age, what kind of medications you're on, your genetics. And so there's a little bit of a question of using this VNP in terms of literature and guidelines. There aren't a lot of like firm literature and firm guidelines. And so our clinical question was, does doing this, preoperative measurement of VNP actually help predict those sorts of complications? And so we used our study design. We looked at, we did a 9-year retrospective single institution study going back to September 2011 to about September 2020. And we looked at a lot of different things. We looked at demographics, we looked at lab values, we looked at procedure mix, as well as the hemorrhagic and thromboembolic complications. We specifically looked at neuroendovascularly treated patients and then individuals who got a VMP, a Verify Now Plavix measurement, and then they got subsequent dual antiplatelet therapy, and we followed them for about 6 months. So we had 317 patients. And the way we divided these patients for our study was we divided them into what's known as platelet reactivity units. And I'll explain a little bit more what that means on the next slide. So in terms of, so this is figure 1, which is the distribution of preoperative Plavix response measured by the Verify Now Plavix. And then when you use Verify Now Plavix, it spits out this platelet reactivity unit. In general, you want to have individuals between the 61 and 214 platelet response units. That's what we call therapeutic responders. And this is in general the target that we try to do for patients who are under dual antiplatelet therapy. There's a small subset of individuals, in this case, we had 51 out of our 317 that are hyporesponders. And theoretically, they're going to have increased risk of stroke, thromboembolic events. Their stent might close up due to a clot. And so we might do things like add a third agent or even increase the Plavix dose to try to compensate. And then we have a smaller subset, about 21% in this case, hyper-responders and extreme responders. This is when you have a platelet reaction unit of below 60, and theoretically you're going to have increased risk of hemorrhagic events. So this is any kind of bleeding, whether it could be intracranially or extracranially, like a GI bleed, for example. And what we found when we did our statistics is that in terms of demographics, all of these groups are the same. We didn't find any statistically significant difference in any of these PRU groups. We didn't find any significant difference in lab values, and we didn't find any significant difference in procedural data. So everyone got relatively the same mix of procedures, whether it be a flow diverting stent, stent-assisted coiling, etc. So now we get to the meat of the talk, which is what was the complication data. So this is figure 2, the complications associated with dual antiplatelet therapy as measured by the preoperative VMP. So the section A looks at the hyper responders, which is this PRU value of less than 60, and the therapeutic as well as the hyporesponders on the right. And we found that there is a significant increase in the hemorrhagic events, which falls in line with previous papers, with previous literature. Whenever you have a hyper responder or someone who really responds to Plavix, they're going to have higher levels of bleeding events. However, unlike those other papers, we actually divided everything up, and we wanted to know what the drivers of those hemorrhagic complications were, because no one really looked at whether or not intracranial hemorrhage was driving it, other things were driving it. So we divided it into intracranial hemorrhage, major bleeds, which we defined as 1, did you need a vascular consult? 2, did you need vascular imaging? Or 3, did you need to give them a transfusion? And what we found was that, oh, and we also did minor complications, which we defined as self-limiting bleeds, so things like nosebleeds, etc. And what we found was that, interestingly enough, the intracranial hemorrhage, there was no significant difference in intracranial hemorrhage in the individuals who were hyper responders versus those who were therapeutic as well as hyporesponders. So what we found was that the major driver of hemorrhage in this case was actually major extracranial bleeds, and most of these were GI bleeds. And so that's an interesting finding. There was no significant difference between in the minor hemorrhagic complications. So these are things like epistaxis, they might have menorrhagia, they might have axis site bleeding, but there was no significant, we didn't find anything statistically significant there. And then for C, we have, this is the difference between hyporesponders, the PRU above 215. So these are individuals who our increased risk of ischemic events, stroke, in-stent stenosis, and then everyone else. And what we found was that, unlike in previous studies where they did find a difference, hyper-responders have increased risk of ischemic stroke, we actually didn't find anything, any difference between those. So in terms of our limitations and the conclusion of my talk, one of the limitations is that this is a single center retrospective study. And so just going back to the this figure, there were about two neurosurgeons as well as two neurointerventionalists who would adjust the dosing of Plavix, or would add a third agent. So we don't know, so because we're looking retrospectively, we don't know which one of those changes actually made a difference in terms of limiting these ischemic and stroke events. The second thing is that we included multiple procedures, and so that really decreases the sensitivity of our study, but that also increases the we're able to generalize our study a lot better, despite having multiple procedures. In previous studies, they might have looked at one particular procedure, maybe they did a flow diverting stent, or maybe they only looked at coiling, for example, but we used multiple procedures. So in terms of the conclusion is that if you happen to be a neurointerventionalist and you are worried about an intracranial hemorrhage or intracranial bleed, according to our study at least, it's relatively safe to continue on with the procedure if you're worried about an intracranial hemorrhage. But you have to be wary that there is a risk of extracranial bleeds, especially in the delayed period, that's 6 months. You might have an increased risk for GI bleeds and other major bleeds. So that's something to be aware of. Our study also indicates that if you make adjustments for the hyporesponders, so these individuals, for the hyporesponders, what we found was that you're able to get it to where there is no significant increase in ischemic events, so risk of stroke. So in terms of like whether we should keep using this VMP, there is still some utility in using this Verify Now Plavix, but in terms of predicting intracranial hemorrhage, it's not so useful for them. And so in order to validate our study, the next step is to look at a multi-center prospective study, and that should help clear up any questions that we might have.
Yeah, so thanks so much, Dr. Ellenbogen, for that introduction. I'm excited to be talking to all of you today about some of the data from my PhD work, specifically focusing on extrasynaptic serotonin receptors and how they regulate reward-seeking behavior. And so neurotransmission of serotonin, or 5-hydroxytryptamine, 5-HT, is very complex. And if we take a closer look at serotonin release, we see that it occurs in several ways. One of these ways is through synaptic transmission, where serotonin is released into the synaptic cleft and interacts with postsynaptic receptors. Alternatively, serotonin can undergo volume transmission, where serotonin is released into the extracellular space and allowed to diffuse and interact with extrasynaptic receptors. And one of these receptors I'll be talking about today is the 5-HT6 receptor. 5-HT6 receptors are particularly unique. They are GS-coupled excitatory receptors, and they localize to neuronal primary cilia. Primary cilia are signaling organelles that are found on the cell bodies of neurons, and they allow the cell to sense molecules that are diffusing throughout the extracellular space, almost like signaling antenna. And it's here that we see 5-HT6 receptors are localized. And in addition to the extrasynaptic ciliary localization of these receptors, what's also particularly intriguing is that they're most abundant in the striatum. And so this image shows radio-labeled 5-HT6 receptors in the rat brain, and you can see that they're highly expressed in both the ventral and dorsal striatum, and this is true in humans as well. And so to really understand what these receptors are doing, we first have to look at what these brain regions are doing, and specifically, the nucleus accumbens is a region that is critical for goal-oriented and reward-seeking behaviors. And so since these extrasynaptic serotonin receptors are particularly abundant in this brain region, I wanted to ask the question, do 5-HT6 receptors in the nucleus accumbens modulate reward circuits and reward-seeking behaviors? And so if we take a look at our model organism, the rat, we see that the nucleus accumbens has two main output pathways. The direct pathway projects directly to midbrain nuclei and generally works to promote behaviors and actions. And these neurons selectively express the neuropeptide dynorphin. In contrast, the indirect pathway projects indirectly to midbrain nuclei through the ventral pallidum and generally works to inhibit actions. And these neurons express the neuropeptide enkephalin. And this differential expression is really important because in order to study the effects of 5-HT6 signaling, I wanted to increase 5-HT6 expression in a pathway-specific manner. And so to do this, I took advantage of this differential expression, and I used herpes simplex viruses that coupled the expression of 5-HT6 receptors to the expression of dynorphin or enkephalin. So I injected stereotactically these viruses into the nucleus accumbens, and specifically with the dynorphin-driven 5-HT6. This increased receptor expression specifically in the direct pathway. And I used enkephalin-driven viruses to specifically overexpress 5-HT6 in the indirect pathway. And then I also used dynorphin and enkephalin green fluorescent protein viruses as controls. And what's interesting to note is that we do see that with exogenous 5-HT6 expression, shown here in green, that these receptors do co-localize with cilia markers, shown here in blue, showing that the exogenous receptors can make their way to the neuronal primary cilia. And so in order to look at how these receptors regulate reward consumption, I used a cocaine self-administration model in rats. And in this model, rats are placed into an operant chamber and allowed to press an active lever for an infusion of cocaine, which is very rewarding for them. And so I began by looking at the effects of increased 5-HT6 expression in the direct pathway. And this graph shows the average number of cocaine infusions during each 2-hour session. And what we see is that there is no significant difference in the amount of cocaine consumed between controls and rats with increased 5-HT6 signaling in their direct pathway. And this is true when we look at the average number of infusions. What was interesting is that when we look at rats with increased 5-HT6 signaling in their indirect pathway, we see that these rats take significantly less cocaine across these sessions. And also that when we look at the average number of cocaine consumed, this drops by about half in these rats. What was also interesting about this increased expression is that when we take a look at the concentration of cocaine in their brains, we see that compared to controls, rats with increased 5-HT6 signaling in the indirect pathway titrate around a lower concentration. So they're taking less cocaine in order to maintain lower concentrations of cocaine in their brains. Now, this was a really interesting behavioral pattern. And so I wanted to ask what was driving this behavior? What was driving this reduction in cocaine consumption? And so one possible explanation is that increased 5-HT6 signaling in the indirect pathway is altering their movement, which would make sense because basal ganglia circuits are critical for regulation of movement. And so in order to test this, I placed rats into a chamber with a laser beam grid and measured their movement throughout the grid over the course of 30 minutes. And what I saw is that there was no difference in locomotor activity between controls and rats with increased 5-HT6 in the indirect pathway, showing that this manipulation is not altering their ability to move and press the lever. One other explanation is that these rats are consuming less cocaine because they're less motivated to take it, and that this manipulation is altering motivational circuitry. And so in order to test this, I used a progressive ratio paradigm. And in progressive ratio, rats begin with a low ratio schedule, so one lever press results in a single infusion of cocaine. However, they have to work increasingly harder to get an infusion. So in order to get subsequent infusions, they have to make more and more lever presses. So they begin one lever press, results, if they make one lever press, they get an infusion, then they have to make 2 lever presses and 4 and 8 and 16 and so on. With the idea being that animals that receive more infusions have a greater motivation to work harder for those infusions. But interestingly, we see that when we look at rats with increased 5-HT6 in their indirect pathway, we don't see any difference in the number of cocaine infusions compared to controls, showing that this manipulation also isn't affecting their motivation to consume cocaine. So 1/3 explanation is that increasing 5-HT6 signaling in the indirect pathway is altering their sensitivity to the rewarding properties of cocaine. So in other words, if because they're more sensitive to it, they need less cocaine in order to achieve their desired effect. So in order to test this hypothesis, I used a conditioned place preference test. And conditioned place preference testing uses a large chamber with 2 side rooms, each with completely different contexts, different floor textures, different wall colors, different lighting. And control rats and rats with increased 5-HT6 in their indirect pathway are placed in a random counterbalanced fashion into one of these chambers and given an infusion of saline. They're then put in the opposite chamber and given a very low dose of cocaine that has been shown in control rats to not be rewarding and not produce any behavioral effects. Then on test day, I measured the amount of time spent in the cocaine paired chamber minus the amount of time spent in the saline paired chamber, with the idea being that rats will spend more time in the room associated with the more pleasurable and rewarding stimulus. And what was very interesting is that rats with increased 5-HT6 signaling in their indirect pathway showed a significant preference for the chamber paired with this low dose of cocaine, indicating that they did have an increased sensitivity to the reinforcing and rewarding properties of that drug. So overall, what this data shows is that extrasynaptic 5-HT6 receptors in the nucleus accumbens can modulate reward-seeking behavior in a circuit-specific manner. And specifically, increased 5-HT6 signaling in the indirect pathway reduced cocaine consumption by actually increasing the sensitivity to the rewarding properties of this drug. And this has a lot of implications. Extrasynaptic serotonin and primary cilia signaling in general can actually be very important for regulating basal ganglia circuits, and in particular, regulating sensitivity to reward within the nucleus accumbens, which has implications for neurological and psychiatric diseases. And so I've worked on several follow-up experiments as well. And in particular, I've developed these CRISPR-Cas9 viruses that work to knock out 5-HT6 receptor signaling in a pathway-specific manner. I'm also working on investigating whether 5-HT6 signaling affects other reward-seeking behaviors. So sugar consumption, social interaction, and even food consumption as well. And over the past 1.5 years, I've actually been very interested in determining the role of primary cilia signaling in general and how the primary cilia regulate pathway-specific behaviors. And so with that, I would like to acknowledge all the current and former members of the Neumeier Lab, my thesis committee, as well as my funding from the NIH and the ARCS Foundation.
So my research is on instrument-assisted soft tissue mobilization, or iSTEM, and we studied the forces being applied through that. So what is iSTEM? So instrument-assisted soft tissue mobilization is a therapy that many people on this conference may have seen or experienced. It's quite popular. It's a therapeutic intervention used for myofascial rehabilitation and chronic pain, surgical recovery, or overuse conditions. How that works is the hypothesis is that it creates an acute inflammation that enhances fibroblast activation and collagen alignment and maturation. And so that definition can kind of sound a little bit confusing, but if you've ever had shin splints or you've been exercising and strained a muscle and gone to receive care, they would have used one of these devices seen on the right side of your screen to stroke up and down the muscle or where you have pain. And that helps to establish recovery, really just increase the time it takes to recover. So as you can see, there's quite a few different various instruments that can be used to apply that pressure. And these can also be done with one hand or two, depending on the preference of the person implementing it. This application is done through trained clinicians. There's a training course that goes along with how to apply the instrument, direction that you should be doing it, and how much force should be used. One of the caveats, though, is that as popular as it is, no one's really studied how hard you should push. And so there's really a lack of understanding. And depending on who you go to, they might press really hard or they might just barely stroke your skin. So our objectives were to establish a literary standard. In this research that had been conducted, very few people were actually citing how hard the forces were being applied, just that they were stating the fact that they had been using these, the protocol. So one of the problems we found is that we'd read something and it would say a feather stroke was applied, or they wouldn't even cite a force. So we wanted to look into setting a standard there. The second thing we wanted to do was quantify what the current clinical practice was. There's prevailing bodies of thought on how much force should be applied. And the first is more is better, kind of an understanding that if you're pushing really hard, making the change. The second is it doesn't really matter how hard you push, just the fact that you're doing something is having effect. Some people wonder if that's placebo versus actual force, and literature does indicate that there is something more than placebo there. And then the third is that it's just the stimulation of the skin enacts your body to cause the repair, and pushing harder will not give any added benefit. And rat models kind of support more of that there, less is more, but you do have to push a certain amount. And then the last thing we wanted to look at was bridging the gap between the current models in the lab. There's been quite a bit of research done on rats, and seeing if that's being applied in the clinical field, and really see how hard, again, is being pushed. And if you look at the literature, 20% in one study claimed they rarely or never followed the recommendations of their training. So they weren't pushing or using the force that was encouraged. And then in another survey, 80% did not know how much force they were generating. They were unable to quantify it. So for our method of our study, we had 11 licensed clinicians that participated. They had all completed professional iSTEM training. And of those 11, 2 were physical therapists, 2 were chiropractors, and 7 were athletic trainers. In the study, we used instruments. You can see to the right that there is a skin simulant. It contains subcutaneous fat and fascia, as well as a force plate underneath of that. And so our intervention was to have our participants receive a hypothetical treatment scenario, and then they were going to apply pressure depending on how they would treat that. Our scenario was reported calf tightness. In the intervention, our participants performed 5 one-handed sweeping strokes, and then in our second study, they performed 2-handed sweeping strokes. They did these with the 5 instruments that I previously showed at 3 different times. So a total of 75 data points were collected for each participant. And then in our second study, we also had a questionnaire gauging with the 2 hands what methods were, the clinicians answered questions regarding their training that they had received, the experience, how many years they'd been applying the forces, and then subjective interpretation of how much force they thought they were applying in our scenario. So in a one-handed study, the average peak forces produced by our sample of trained clinicians was 6.7 newtons, and the average mean force was 4.5 newtons. The conclusion there was, in our data, reported that in this study, there was a wide range of forces for researchers to examine when assessing different ISTEM force applications on patient outcomes. The observed force in our studies were similar to those reported in previous literature, however, to the gastrocnemius of healthy individuals. However, we noticed that the force was greater than what had been reported as effective in rat models. One of the things that needs to be looked at is how rat models and the force applied to their muscles and fascia relates to human models. In our second study, we looked at two hands with the instruments, and it was found that the average peak force was 8.9 newtons and an average peak force of 6 newtons across all instruments. So in comparison, the one-handed study had lower force applied, and the two-handed study had a higher force applied for our great peak and mean forces. In the questionnaire, our participants were relatively accurate in estimating how much force they were applying. However, participants generally estimated and produced forces greater than what was needed based on clinician estimates. So in conclusion, if you look over at the box and whisker plot, you can see that most participants used kind of a similar force range depending on the instrument. However, the forces utilized were greater than what's been estimated as being efficient. And so going forward, we're currently trying to figure out what force for humans is the best range, and then we'll be able to try to implement instruments that can gauge that force for clinicians going forward, kind of bridge that gap for a clinician to know how hard they're pushing and what range they should be pushing in for the optimal outcome. I just want to give a thanks to Dr. Baker. He was a great resource in the biokinetics lab for me in helping this study take place.